Hello and welcome to the another session, and this session here we're actually exploring communicating for safety. So this is very pertinent in relation to the specific written communication that involves nursing practice. As always, the copyright process applies. So when we actually look at the Nursing and Midwifery Board RN standards for practice, we actually see very clearly that written documentation is actually threaded throughout the 7 standards. So you can actually see in standard number 1 that is specifically relating to that specifically relates to thinking critically and analysing nursing practice. Standard 1.6 applies. When we see standard number 2, which is engages in therapeutic and professional relationships, 2 of the standards apply, and then likewise with standard number 3, which maintains the capability for practice, there's a pertinent role for written communication. And again in standard number 5 and standard number 6, and the final standard which evaluates outcomes to inform nursing practice. So you can see the very important thread that written communication has in our RN standards for practice. Now, the Safety and Quality Health Service standards, they also talk about the documentation of information, and specifically they report on the timely, complete, accurate, confidential, and being specific to the individual. What I would encourage you to do is actually have a look at this the quality and safety standard, specifically around that written communication. So the Royal Perth Bentley Group actually is one of the policy guidelines that we have been fortunate enough to use for student learning in the laboratory and simulation area, and you'll actually see that you can access the practice standards relating to documentation and communication from the clinical hub. So what you need to note is that written communication is completed on admission, discharge and transfer on all documentation, and that's both bedside as well as the patient record. And all student nurses, when completing the patient record, all student nurses are required to have their documentation to be countersigned by the RN who is supervising them. You also need to understand that the view taken that if it's not documented, it's not done. And needless to say that nurses and midwives spend significant time documenting their practice. So what is the purpose of patient records? There are a number of purposes, so communication both within the team and for the person themselves. Patient records can be accessed and can be viewed by the patient at their both inpatient care, and can be accessed post-discharge through the Freedom of Information Act. So it's a communication tool. It's also a process where planning patient care is actually planned, because sometimes it's not always possible for the whole team to actually get together to see the patient at the one time. Whilst there's been improvements in that practice, there's still sometimes a challenge in that area. So it's a central point of planning. It's also used for auditing, for research, for education, for financial reimbursement from the hospital where procedures are actually categorised, and the hospital seeks reimbursement from the government for that care episode. Clearly for legal reasons, for healthcare analysis when their practices are changing, and of course for professional conduct. So always making sure that you are legally and professionally compliant with what needs to happen is always recommended. So good practice is always to write contemporaneously, date and time of entry, avoid double documentation, only use approved abbreviations, strike through blank spaces, nursing students must sign, print their legal name and write their designation and preceptor's countersign, and then there's a strike through errors and add written in error with the date, name and designation of the author. So no whiteout and no scribble is actually permitted. Some of the errors that occur are incorrect patient time, date, no signatures for verbal orders, incorrect data or inaccurate measurements, omissions. Remember, if it's not documented, it's not done, and any advanced charting. If the document is illegible, not dated or signed, and abbreviations must be medically recognised. So documentation systems, there are a variety of systems. There's integrated record keeping, there's source-orientated record, problem-orientated medical records, the problem intervention and evaluation model, the PI model, focus charting, charting by exception, computerized documentation and case management. Now you may use many of these on your first prac, or perhaps only one or two of them. But what will happen is that over time you'll be exposed to all of these varied documentation systems, and accurate, timely, appropriate and contemporaneously charting is always required. So when we're looking at nursing documentation, this is in the patient file. We use the DAP or the SOAP process, and this is around a summary of what's happened to that patient in care at throughout your shift. So DAP stands for Data Analysis and Plan, or we can also use SOAP, which is Subjective or Objective and Analysis or Plan. So the data in the SOAP format is a combination of subjective and objective processes. It's just what we do is we separate out what the person tells us rather than what we infer. And then of course there's systematic documentation, and that might be a head-to-toe approach that's actually used in some settings, or it might be the ABCDE approach that's actually used to documentation. So rather than using the ABCDE, we refer to it as A to E. So when we're looking at DAP, for instance, the data is about what the patient says, and the observation or objective information is what is observed by the health professional, or what your assessment actually indicates. So for example, the patient's heart rate is 110 beats per minute, and they're displaying some facial grimacing, and the patient is complaining of pain and reports a pain score of 8 out of 10. So you can see here that there's a combination between subjective and objective information, but it's been grouped together to actually tell a story. And so then when we look at the analysis actually looks at interventions, assessments and the patient's response or progress. And an example might be that patient in pain requiring oral analgesia as prescribed and with good effect. And the patient states that the pain score was 5 out of 10 within 30 minutes of administering the analgesia. So you can actually again see that the story's been expanded to actually see even in intervention has been applied, what was the effect of that intervention. The plan, which is the last part of the DAP, and this is where there's a revision of interventions, and this is based on interactions or assessment of the patient. And an example here is continue to assess pain hourly, which is what the 124 means, and administer regular pain relief as required. So if we were to put that story together, we would actually be saying the patient's heart rate of 110 beats per minute, they're displaying facial grimacing, and they're complaining of pain and report a pain score of 8 out of 10. The patient was in pain. They required oral analgesia as prescribed, and this was given with good effect. And the patient states that the pain score is now 5 out of 10, and that was within 30 minutes of an administration of analgesia. We want to continue to assess pain hourly and administer regular pain relief as required. So what I'd like you to do is to think about Mrs. Kendall, and so Mrs. Kendall, and translate the following progress note, the following case scenario into a progress note. So Mrs. Kendall says her ankle is painful, and you can see that it's swollen following her fall in her home. You make her a cup of tea. Mrs. Kendall was seen by the local GP and was found to have no injuries requiring medical management. She says she's worried about falling over again. So check the web link here to give you some guidance on how to advise Mrs. Kendall, and then use the case notes and the information you found on the website to write an entry into her progress note. So you might want to have a try of this and bring it to class in preparation for discussion. So when we're looking at nursing documentation, we often look at high acuity settings. So systematic documentation headings, we're looking at central nervous system. So in this here, we're looking at pain, the full neural observations, speech, behaviour, seizures or temperature. From a cardiovascular perspective, we're looking at blood pressure, heart rate, central venous pressure, intravenous access, IV therapy or infusions, and neurovascular observations. The respiratory system, we're looking at the rate, the percentage of oxygen-inspired air that is being taken, what their oxygen therapy is, whether there's any sputum, nebs, any chest x-ray, or whether they've got a tracheostomy. And then our kidneys, we're looking at the presence of an indwelling catheter if they're voiding, and their full fluid balance chart. Gastrointestinal tract is around their diet, any nausea and vomiting, their bowels, a nasogastric tube, if there's any aspirate, and what their swallow is like. And their endocrine system, we look at blood sugar levels, whether they're prescribed insulin subcutaneously or on an infusion. And their integument or their wounds, we're looking at skin, pressure area care, mouth care, drains, sutures, signs of infection or any dressings. And of course the musculoskeletal system, we look at mobility, sitting out of bed, their rehabilitation, the use of splints, any exercises and any ambulatory aids they might be having. So the social looks at visitors, phone inquiries, communication, reprognosis or treatment. So you can see that the plan is very detailed. It's treatment, it's patient education, and it's around investigations and discharge. So when we're using a systematic documentation process, we use headings and we group our observations or our context according to that, according to the system. So this is a very important process of documenting information as well. So, and this is very much a system that is not only suggested by Royal Perth Hospital, but also endorsed by other hospitals in their practice areas. So when we're looking at nursing documentation, let's say from a critical pathway, a critical care delivery, we're looking at the A to G approach, and this is airway, breathing, circulation, disability, exposure, family and glucose. And this A to E approach is suited to critical care areas such as ICU or ED, where airway becomes the priority. So some practice guidelines for documentation: don't leave blank spaces, chart in advance, use vague terms, chart someone else's progress, use patient or client as is their chart, alter a record even if it's requested by a superior or a doctor, and record assumptions or words reflecting bias. What you should always do is chart a change, read notes prior to giving care, be timely, use objective, specific, factual information, descriptions, correct charting areas, and chart all teaching, record patients' words, and chart clients' responses to interventions, and review any pertinent notes. So general guidelines for recording are around date and time, include the date and time, the time in the sequence, the legibility, ensure correct spelling. It's a permanent record, so be mindful that it can be viewed by a person when they choose to, and when they enact the Freedom of Information Act. Use accepted terminology and ensure your signature is in place. It's about accuracy, sequence, appropriateness, completeness, conciseness, and legal prudence. So charting should be contemporaneous, it should be accurate, follow the chart instructions, use colour coding, observe, track and trigger an intervention if indicated. And know that the ethical and legal considerations state that the Nursing and Midwifery Board of Australia state that nurses treat information obtained in their professional capacity as confidential. Healthcare records and privacy information, all health information, both public and private, must be kept confidential in all forms, including verbal discussions. Patient records are protected legally as a private record of the patient's care, and access to patient records is restricted to health professionals involved in giving care to that person. And students' access to patient records is allowed for education and research, but must be de-identified. The institution or agency is the rightful owner of the patient's record and does not exclude the patient's rights to be the same in the same record. So we are mindful that it is all about the person and the hospital requirement. So ensuring confidentiality of computer records is there's restricted access, it's personal password required to enter and sign off. Don't share your password with anyone if you're ever given a password as a student, and then as a registered nurse you can't give your login to someone else. After logging on, never leave the terminal unattended. Don't leave client information displayed on the monitor in full view, and shred all unneeded computer-generated work that relates to the patient. Know the organisation's policy for correcting an entry error, and follow the agency procedures for documenting sensitive materials. Firewalls should be installed by an IT person. So here are a couple of quizzes for you to try and see how many of you actually get this quiz correct. So what I'd like you to do is to complete this quiz and bring your answers to class where they'll be verified. So which of the following regarding the legal requirements of documentation is not true? The entry must be legible, 12-hourly clock format must be used, there must be no blanks areas, it must be signed with a printed name and designation. Okay, so what is not correct? Which of the following statements is correct in regard to documentation? All documentation is the same for every patient and every patient condition. It's acceptable to use the abbreviations that your facility approves of, and spelling and grammar are not important. All of the choices given, so select what is correct. And then the third question, I won't read that one out, but have a look at that one for yourself. Okay, all the best, and I look forward to your input into the next session.